Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, I am super excited to finally put out there a concept I have been thinking about for, I think, a year and a half now. And it all stemmed from when I did that rural emergency medicine episode. And I got to thinking that something's missing from the way critical care and resuscitation education is done in emergency medicine. I put stuff out there, but there are still EDs. I visit or speak to people who work there, and I find that the baseline level of care is not necessarily care that is in keeping with the current thoughts on the optimal care of a sick patient. And I think it's because, there's all these amazing initiatives, whether it be in the conventional media space or the foam space or the new media space, and all of this great information is out there, but the information doesn't penetrate to the baseline culture of the specialty. I think what's needed is a different approach. I think we need to establish an absolute standard below which care will never drop, no matter where you are. You could be in a rural place, you could be in a suburban place, you could be in an urban place, level 1, level 3, it doesn't matter. This is the absolute baseline for care. And then some places may exceed that, may go further, but no one should be allowed to go lower. And as I started letting this percolate in my mind, I realized what I think the solution is to have a set of guidelines, not forced upon you, not, CMS measures, but just guidelines that we agree to as a specialty is the very foundation. And I go to places that are, big centers. This is not a problem of rural medicine. I go to places that are big centers and their foundational care is not good. So this project, which you're going to hear introduced for the first time today, is the project of foundational stabilization. Foundational stabilization. This is the absolute minimum that any critically ill patient should be able to expect anywhere in the country. I mean, because I'm not going to expand, even though I have an international audience. I'm just going to shoot for the U.S. here, but anyone's willing to take this. So this is the foundational level of stabilization. Now, why stabilization? I think any specialty, and because many specialties are actually caring for patients in emergency departments, in critical access hospitals, in clinics sometimes, that's the only place you could go. This is a stabilization level of care is, if you can't provide amazing critical care, you still could provide stabilization until the next level of care takes over. So the project is foundational stabilization. And what I envision it as is this long, not particularly high rectangle that's broad, and all the other more advanced resuscitation and critical care sits on top of this. I'll put a diagram in the show notes, but you get the idea, right? This is the foundation upon which that better care is built on. This is the absolute standard that every residency should be teaching, whether it be family practice, whether it be emergency medicine, whether it be critical care. This is the baseline. If you could do better, then build upon it, but never go below it. Now, how is this project going to work? Step one is to put out a podcast like the one you're hearing today. Now, you might say, oh my God, that shouldn't be step one. That should be step whatever the very end of the process is. After you've worked all this out, you've done your grading group, you've gone back and forth in modified Delphi, you've talked it out, you've vetted it, you've sent it to other societies, and then you put it out as a podcast. Yeah, no, I see that. I see that's how standard guidelines are done. I'm not doing it that way. I'm doing it a different way. I'm going to put out a provisional guideline right up front. Why? It's because of Cunningham's law. Cunningham's law says the way to find the right answer on the internet is not to ask a question. You will get very little response, and it's an excellent chance that the people actually responding won't have the right answer. Instead, Cunningham's law says put the wrong answer out there. Put the wrong answer out there deliberately, and what will happen is you will get an enormous response of people telling you how stupid you are because here's the right answer. And you are far more likely, due to the increased number of people that reply and the more likely scenario of the person who actually knows the best answer being too lazy or busy to reply to your dumbass question. It's like, look it up, jerk. But they will happily tell you what an idiot you are since they know better. So I am using the power of Cunningham's law So I'm going to put the provisional guidelines out there as an EMCrit episode. I'll label them provisional. Don't start using these. And then I want to harness the power of my brilliant audience to tell me where I am wrong. Please, please. So the episode goes out. We get a lot of public commentary. At the same time, we're getting the public commentary. And this could happen either before the episode is released or right afterwards, depending on which way this episode's go. It's going to be disseminated to the Stabilization team. And from now on, I will just call it FoundStab because that's how I think about it in my head. The FoundStab team will get the podcast as well. They might have seen it before the podcast. They might see it after. And they will weigh in. And this group is going to include some brilliant people. If you're interested in being part of this group, let me know. But I already have some people in mind who I want from the various areas of critical care, rural, regular emergency medicine, pharmacology, etc. And we take the listener response, we take the FoundStab response, we edit this provisional guideline, we put it back out there again for public commentary, we get additional thoughts there. At the same time, a separate group is grading, by which I mean the grade system for guideline analysis for evidentiary basis and for level of recommendation. That's happening. Then we'll put that out there, we'll send it to the major societies, get their opinion, and then finally put out a finished Stabilization guideline, a FoundStab guideline, that hopefully will be able to be used for the education of emergency medicine and other resuscitative specialties. So that's the dream. Curious to hear what you think about that as a general project. But let's go into the actual one I want to put out there today, and it is post-intubation sedation. Now, why this one? Is this the one that is most life-saving if we get it right? Maybe not, though I think there definitely is aspects to that. But it's the one I see done most often wrong when I visit places and speak and talk to people, both at big centers and little centers, both rural and urban. So that's why this is the first one, and it's just been on my mind. And the thing I should also say about the project is the foundational stabilization will be at the level of low resource, right? Because that's the resources, whether they be person resources, whether they be equipment, et cetera, is what separates out low resource from high resource, this capability to do high level critical care. That's why this is the foundation. So it's going to be as low resource as possible, but there will be some resources that some places don't have. And then part of the foundational stabilization guidelines will be to demand those resources. So let's have an example of that. End-tidal CO2 for every patient who has a airway device in, whether it be LMA, trach, or endotracheal tube. That's the demand, not just for the intubation, continuous end-tidal CO2 monitoring for any patient who has an airway device in. Well, some places don't have that. Some places have one, but if there's two patients, then they're hosed. Hey, guess what? That is a minimum resource. You got to get it. There's just no acceptable way you should have a patient with an airway device who's not being monitored by continuous end-tidal CO2. Boom! So now the foundational stabilization guidelines become a demand for minimal resources at every place that does resuscitative care. Okay, so now your administration has to buy that if they sign on to the eventual foundational stabilization paradigm. All right, so let's get into it. So I have, let's see how many I have here. I have 10 pieces of this first guideline from the Foundational Stabilization Project. Number 1, use propofol over benzos. A lot of places are still using benzodiazepines for their post-intubation sedation. Not acceptable. Use propofol. Now, you might say, well, what about dexmedetomidine? Dexmedetomidine is a higher level of care. Knock yourself out. I love it. It has some problems. It requires a little bit of time to kick in, so you're not going to get immediate sedation. So propofol, even when I use dexmedetomidine, I always start with prop. Just don't use benzos as the mainstay of your sedative regimen. Use propofol. So propofol becomes the foundational sedation, post-intubation. If you want to use something different, if it's better, dexmedetomidine, or the same, great. If it's better, the same, ketamine, great. If it's not as good, and we have clear evidence benzos are not as good for this, then no more. Stop doing that. All right, so use prop. 2, standard propofol dosing is 10 to 50 micrograms. You can go higher if need be. Now, oftentimes, the need be is you didn't put them on a pain regimen. We'll get there. But you can go higher, but that's the standard, all right? Now, guideline 2.5 is if rocuronium was used for your muscle relaxant, for intubation, then you should be using higher doses of propofol. And these doses depend on how old the patient is, with younger patients requiring much higher doses, usually over 100 micrograms, and older patients potentially requiring reasonable doses, 20 or 30 micrograms. So either use high-dose propofol, which most people will be too concerned to do, or their hospital guidelines will prevent them from doing, or give midazolam 2 milligrams. Now, this one could be contentious. Tell me what you think about this, because there's no great level 1 evidence for this. We know it is a potent amnestic agent, and therefore patients will not remember if they have any awareness of their paralysis. That is why this recommendation is there. Comment on it if you don't like it. If you like it, comment on it too. So 2.5 is, if rocuronium was used as a muscle relaxant, use either high-dose propofol until the patient emerges from their muscle relaxation, or give midazolam 2 milligrams. All right. Number 3, use a sedation scale to allow titration of the sedative and to allow orders to be placed that allow nurses to titrate the sedative without the intervention of a doctor. We recommend the RASS, the Richmond Agitation Sedation Scale, but if you're using something else, that's fine if it works for your hospital, as long as it's been validated. Things like the SAS, right? The Ramsey. But if you're not using one already, we recommend the RASS. I think it's the most adaptable. I think it makes a lot of sense. Your target for that should be sleepy but arousable. Now, depending on your level of monitoring, if you have a high level of monitoring, you might make the patients lighter. If you have a low level of monitoring, you might go a little bit deeper to where they're still arousable, but it's arousable to touch rather than just voice. And it just depends on your hospital. But sleepy but arousable is where you want to go. You don't want a patient who is unarousable as a result of their sedation. All right, now we move to pain. You might say, what? We should have done pain first. A1 sedation, Scott. You've talked about it forever. Yes, that is a higher level of management to do analgesia first or analgesia only sedative strategy, right? So that's great. It's not foundational. Foundational is you start off with propofol to keep the patients non-aware of their paralysis or of their misery, and you add in pain meds too. So it's analgesia there, but not analgesia first for foundational versus optimal. So start with a bolus of pain medication, whether that's fentanyl, morphine, or hydromorphone. Now, if you're transferring the patient, start a fentanyl drip. Why do we have this one here? It's because the patient will also need pain control during the transport, but oftentimes if there is not a fentanyl drip there, depending on the individual protocols of paramedicine at that place, they may not be able to administer pain medication. If the fentanyl drip is there, then allowing that to continue and possibly being titrated gives the patient a better option and has the opioids there. Now, if you're transferring to a paramedicine service that you know they have the ability to give as much pain medication as necessary, then, alter this. That's fine. But in general, if you're transferring, a fentanyl drip makes a lot of sense. If you're keeping the patient, intermittent pushes of morphine, hydromorphone, or even ketamine is the way to go. Number 7, use a pain scale with hourly assessments. If you don't already have a pain scale at your hospital, we recommend the CPOT. Again, if you have one that works, great. If not, use the CPOT. I find it the easiest. I find it has the most evidence behind it. And it's not magical. It's there to allow nurses to have a standing order for the additional administration of pain medication, which in most states in the U.S. you can't do unless there is a scale attached to that order. So hence, use a scale and hourly assessment, and then give patients more pain medication if it's deemed necessary. All right, number 8. Do not titrate pain or sedation for hemodynamics. This is the one I see missed most often. The patient slightly drops their blood pressure, which is an expected phenomenon after intubation. And instead of doing what should be done, the nurses, and I don't blame them for this, they have no other options in front of them, lower the sedation or turn it off or hold it. And this is not acceptable, especially if the patient's just had rocuronium. But even without that, holding pain medication and sedation for hemodynamics is not the way to play. Now, look, if somehow the propofol got up to 90 micrograms and the patient plummets their pressure, that's a different story. We're talking about the dose that was working great for the patient's sedation. Once they get hypotensive, gets turned off, is not the way to play. So number 8, don't titrate pain or sedation for hemodynamics, only for pain and sedation. Number 9 is giving back the option to the nurses to allow them to now have something better to do than turning off the sedation or pain control. So number 9 is have norepinephrine hanging at the bedside with a standing order placed for may start at MAP of less than 65 for every single patient you intubate. At the same time you're asking for the propofol and the pain medication, you should be asking for the norepinephrine. Now, ideally, not foundationally, but ideally, the time you're asking for all those things is before you intubate, not after you intubate, but that will leave for optimal care. But norepinephrine should be hanging at the bedside with a standing order for initiation at MAPA less than 65. All right, and now number 10, the one I think is going to cause most controversy, but I fervently believe in my heart. Intubated patients in the emergency department should have soft restraints placed on their wrists and kept for the duration of their time in the ED without arduous, high-risk documentation or the need for a continuous sitter. This one's big because I know that a few hospitals I deal with on a regular basis, in one of them, because they don't want to get dinged, this is a super high-risk thing for hospitals if their documentation is not perfect, has just stopped allowing the use of soft restraints for intubated patients, with the resulting increase in patients who are self-extubating. And another hospital just said, screw it, we're going to put them all in soft restraints because we don't have enough people to even, stay by the bedside with that sitter, and we'll just risk it. And you know what? If Joint Commission says something, well, we'll just have to accept it. Both of these circumstances are garbage. I remember back 6 years ago when every intubated patient was placed in the soft restraints and nurses would be checking on the patients continuously, which means like every 15 minutes or so. And during that time, they weren't being checked on. What the nurses knew is the likelihood of self-extubation when they weren't in the room was much, much better. As in the patients didn't self-extubate because it's much harder. You have to stick your entire face down to your wrist in order to do it. Now, in either case, either the hospital puts themselves at risk or they put the patients at risk by not using soft restraints anymore. This is stupid. It needs to be gotten rid of. Soft wrist restraints do not require a sitter and do not require the high-risk documentation that violent patient restraints do. I agree. If you put a patient in quote-unquote leathers, I say that because now they're plastic, they should have a sitter. They're a danger to themselves. That's why they got put in high-risk restraints. And they should have documentation done every 10 minutes because these patients are at risk of things like self-harm, like rhabdomyolysis, like what we used to call the syndrome of excited delirium, right? In all these cases, yes, they should have someone watching and there should be constant documentation of a clinician at the bedside. Not for soft restraints for intubation. It's friggin' stupid. Oh my gosh. All right. There you go. The first iteration of the FoundStab project, the Foundational Stabilization Project. It only works if you take the things you liked and comment on them, if you take the things you didn't like and comment on them. In the show notes for this episode, EMCrit.org/359. That address again, EMCrit.org/359. All right, EMCritters, quick diversion. What you're listening to is a free episode. This one's the full episode. I'm not going to cut you off on this one, but you do have to listen to my plea, my real desire for your patients to be as safe as possible when they experience critical illness in your hospital. And the way to do that is for you to have the most cutting edge information on resuscitation and acute critical care. Now, you're getting this full episode for free, but there's a bunch of EMCrit episodes that are curtailed after 7 or 8 minutes, meaning you're only getting a tiny portion of the goodness that will save your patients' lives, that will keep you up to date on the most cutting-edge literature in resuscitation and acute critical care. So if you don't want to hear these messages again, but more importantly, if you want to protect your patients, feel good about your resuscitative skills, then you should join EMCrit. All you have to do is go to EMCrit.org/join. You'll pay a minimal fee compared to the other CME out there. And then your hospital could reimburse you or you could write it off on your taxes. So give yourself a little critical care gift. Go to EMCrit.org/join and become a member. This has been Scott Weingart for the EMCrit podcast saying bye-bye. But of course, it's not really bye-bye because I always mention here medicine coaching. That's the physician performance coaching service I do. I have clients who come to me wanting to take their excellent performance and make it even better, how to optimize, how to increase productivity, how to deal with teams, how to lead. And then I have clients who come to me who are afraid. They are not happy with their career at night. They're burnt out. They are crispy. And in both of those cases, we work together and we actually could solve a lot of the problems or optimize the situation. So if you're interested in that, come to EMCrit.org/coaching. That is EMCrit.org/coaching. Bye-bye.